The broadcast is now starting. All attendees are in listen-only mode.
Hello, and welcome to our CFN webinar today. The topic of today's webinar is shared decision-making for goals of care discussions in the ICU, evaluation of an online training module, and decision aid. Today we have Dr. Patrick Archambault presenting for us. So my name is Amanda Lorbergs. I am going to be hosting today's webinar, and I'm the CFN Manager of Research and KT. At the end of the webinar, we'll aim to get through as many questions as time permits, so feel free to hand in those questions using the chat box on the right-hand corner of your screen. Just as a reminder, as usual, we have a survey that pops up at the end of the webinar. We appreciate all your feedback on how we can continue to improve the series. And we also have the slides and video available for viewing online within a day or two. So you can keep an eye out on the website on our homepage to find out when you can access this on your own time. We are currently in the process of scheduling more webinars, so none are confirmed yet for the future. We will have these advertised on our website as well as on Twitter, so keep an eye on there if you're looking for your lunchtime webinar. Announcements from CFN. We're happy to and excited about our 2019 National Conference on Frailty coming up in September from the 26th to the 27th at the Delta Marriott Toronto Airport Hotel. Registration will be opening soon, and all the information will be available on our website as well as more up-to-date updates on our Twitter feed. So keep an eye out on there. And now for our presenter. So this is Dr. Patrick Archambault. He is an associate professor in the Department of Family Medicine and Emergency Medicine and in the Division of Critical Care, Department of Anesthesiology at Université Laval. He is an emergency physician and intensivist, and he's currently working as a CIHR embedded clinician scientist to help improve the care transitions of older adults in different contexts. So we welcome Patrick. So we will hand it over the screen to you now and look forward to your presentation.
There you go. I think you have access now to my screen. I go into the presenter mode. So thank you very much, Amanda, for that introduction. I am honored to be here with you and to share the work that we've been doing in the past years. Before I start, I just want to make sure that I declare that I don't have any conflicts of interest to declare. And if ever you want to send me an email or tweet about this presentation and you want to use my Twitter handle, do not hesitate. I really want to acknowledge the important work that was done by many collaborators in this project, in particular Ariane Plaisance, who's a PhD student under the direction of Annie Leblanc, and medical residents Julien Turgeon and Tommy Jean, who contributed significantly to making this project possible. And I won't name all of the different collaborators and co-investigators in this project, but they've all been very helpful and supportive in moving this project along. I also would like to acknowledge the support that the Canadian Frailty Network has provided to make this project possible, and different other organizations as well that have contributed over the years to making this research program possible. So the objectives of the webinar are to identify the different elements of shared decision-making needed to lead goals of care discussions with older patients admitted to an intensive care unit. I also like to, for you to learn about the online training program and decision aid we developed, and understand the results and limitations from our implementation trial. So the outline of the presentation is divided up into, I would say, three large parts. The first is the introduction, then I'm going to move into after this. Very briefly, I'm going to present the online training program on shared decision-making that we developed, and then move into the results from our implementation project and finish with the conclusion. So to start, the first question is, why was this study important or important to conduct? Previous researchers have shown that older patients living with frailty receive aggressive life-sustaining therapies that they prefer not to receive. Actually, 70% of older patients prefer less aggressive end-of-life care, and 35% of older patients die in hospital, among which 49% receive aggressive life-sustaining therapy. Clinicians are not adequately eliciting patients' values and preferences. And Darren Hyland showed this with 30% of physician orders for life-sustaining therapies that were not consistent with patients' preferences. Many barriers exist to eliciting patients' values and goals, and clinicians, unfortunately, are waiting until the last minute after their patients have actually failed and are unable to participate in a meaningful goals of care discussions to identify their patients' goals of care. A recent study just published in April investigating how intensivists elicit patients' values and preferences, and if they actually do elicit patients' values and preferences, studied 249 family meetings with intensivists. The study conducted a qualitative analysis of the audio recordings and showed that approximately 35% of the family encounters, clinicians had actually elicited the patient's values and preferences. So the conclusion from this study was that clinicians still need better communication skills to identify patients' values and preferences. Now, this study was particular in that it was really with family members of these patients, and the study that we conducted, that I'm going to present to you at the end, is done with the patients themselves. The recommendations that guide us as intensivists are actually supporting a shared decision-making to elicit patients' goals of cares. The American College of Critical Care Medicine and the American Thoracic Society have put out a policy statement that suggests that shared decision-making should be used to engage patients and their families in discussions about care that is congruent with their values. The Choosing Wisely campaign in Canada, in collaboration with the Canadian Society of Respiratory Therapists and the Canadian Association of Critical Care Nurses and the Canadian Critical Care Society, put out their #1 recommendation, which is that we shouldn't start or continue life-supporting their interventions unless they are consistent with patients' values and realistic goals of care. So this led our team to think about what are the knowledge gaps that still exist and why aren't we potentially implementing shared decision-making in clinical practice. And again, many research projects have explored this topic. In particular, Yu et al. In 2015 showed that communication skills and communication support tools are needed to support clinicians in developing empathetic relationships and discussing prognosis. The availability of the decision support tools or decision aids to support goals of care discussions at the end of life is sometimes problematic, as the AHRQ pointed out in 2014 in one of their reports. And the adaptability of these tools to local contexts is another problem that AHRQ raised in 2014. Other elements that need to be considered in the adaptability is the adaptability of the decision support tools to local culture, language, and literacy levels. And so more research is needed to measure the impact of these support tools and to prepare patients and family to discuss goals of care. So this led our team to attempt to develop a decision aid that was adapted to our local context with the input of patients and intensivists at our ICU in Lévis. We used a wiki platform to support the development of this tool and its dissemination. We used or employed a user-centered design process to adapt an existing tool from Queen's called the Queen's CPR Decision Aid, developed by Chris Frank. And we proceeded to adapting the tool to the local culture, language, and format that the clinicians and patients wanted to use. And we share this tool on the wiki website that is on screen at wikidecision.org, and the work that was done to adapt this tool is published in +1 in 2018. This is a brief screenshot of what you might find if you use one of the tools that we embedded in our wiki, which is an online prognostic calculator that helps clinicians share with their patients the prognosis or I would say outcome of CPR based on the GOFAR rule, and using icon array software developed by Brian Zygmunt Fisher and Holly Whitman, who Holly is one of the co-investigators in this project, and helped us explore this visual representation of prognosis post-CPR. So this is a tool that clinicians could potentially use with patients if the patients need this information, and if clinicians feel that they can use it with the patients. So it's not mandatory, it's a tool that's online and the clinicians can access it on their mobile phones. We, in addition to this online calculator, developed a booklet format of a decision aid that has 11 pages, was developed in the simplest of languages as possible, and I use that term because, as you will see at the end of the project, we might still have to simplify even more the language that we use in our decision aid. It was developed in French. We translated it into English, but we haven't validated it in an English-speaking population. During our prototyping phase, we pointed out or observed interesting elements of discussion, that the notion of death or end of life is actually a bit taboo, and physicians and patients avoid talking about it. Unfortunately, health literacy and numeracy is quite low. At the time that we were developing our decision aid, there was a confusion between medically assisted death and dying and the goals of care discussions. This was in 2015, 2016, when there was a very public debate around medically assisted death. And when patients saw us, or when we approached patients to participate in this user-centered design process, patients thought we were actually asking them about if they would want medically assisted dying or not. So there was a conceptual confusion here that was interesting to note. We also noticed quite quickly that the choice of words is really important, and that clinicians use euphemisms, and this can cause confusion in patients. For example, the word partir in French means to leave, and it could actually mean the patient is being asked if he wants to leave the ICU, and not if he accepts leaving in the sense that the patient would accept to die. So we realized that there was an important unmet need in our group of clinicians, and clinicians and medical students, that there's communication skills training and training in shared decision making about goals of care that was needed. And this led us to develop an online shared decision making module that is available online. You can, if you want to consult it, it's in French. Hasn't been translated yet, but it is free. So if you want to consult it, the web address is on screen. And it's a module that was developed in collaboration with a student in educational technology at SAVI, which is a Société d'apprentissage à vie, a part of the TELUC University. The student, his name was Frédéric Noiseux, and he helped us develop the online content in collaboration with 3 other experts who had previous existing programs that were not specifically adapted or created for the concept of shared decision making. And we worked with them so that we could use different elements of their presentations, and they actually reviewed also our online training module. The average length of our presentation is approximately 1 hour. So very briefly, what we cover in this presentation or this online module is the importance of needing to discuss goals of care for this high-risk population, because these patients are being admitted to the ICU and are at high risk of needing aggressive life-sustaining interventions. And these interventions might not be appropriate and might not be what these patients want, because the discussion is not, the discussion hasn't been appropriately conducted before the patients arrive to the ICU, unfortunately. And it's also a difficult skill to teach students and residents. So this is really an overview of what we're asking physicians and students to learn about. The difficulty resides in the fact that it has to be, I would say, modeled and repeated many times before clinicians really feel comfortable in leading these types of discussions. So the online module is really an introduction, and we are aware that it isn't the only training that clinicians would need. So we present what shared decision-making is, and we define shared decision-making as a collaborative process that allows patients and their surrogates and clinicians to make healthcare decisions together, take into account the best scientific evidence, as well as patients' values, goals, and preferences. And that part of shared decision-making is really what is important for the goals of care discussions. Patient decision aids now are really intended to support shared decision, the process of shared decision-making, and they are really intended to help people participate in decisions that involve weighing the benefits and harms of treatment options that have scientific uncertainty. And the evidence for decision aids show that they increase patients' understanding of their condition, they reduce false expectations, they may increase values, congruent choices, and they may reduce care that will not be beneficial to patients. So the essential elements of shared decision-making are, as pointed out by Clayman and Makul, that there are 9 elements that need to be integrated in the shared decision-making process. The first one being the importance of defining and explaining the problem to the patient, the presentation of options, the discussion of the pros and cons of the different options. It's important to explore patients' values and preferences. It's also important to discuss with the patient their ability and their self-efficacy in making a decision. Then it's also important that doctors do share their knowledge and previous experience and their recommendations to the patient, so the patient can also understand what the doctor is suggesting. It's important to clarify and to check the patient's understanding, and at the end of the process, either making a formal decision or explicitly deferring the decision, and then following up with either the decision or the importance of following up on making a decision eventually. So in our presentation, we really briefly present we go into depth in the presentation about our decision aid, but here today I'll only show you the first page of this decision aid that explores and defines what goals of care are, defines what CPR is, what mechanical ventilation is, explores with the patient what their important values are, what their preferences are, and tries to help the patient come to an understanding of the different options they have. This is a decision aid that is really not meant to replace the clinician's discussion with the patient, but is there to support the discussion. So the research project that we conducted was to determine if our online train module and context-adapted decision aid would increase the adoption of shared decision-making and the quality of goals of care decision-making with older patients admitted to our ICU and NV. The secondary objectives were to identify the most frequent misunderstandings, concerns, and questions patients have during goals of care discussions, and identify the most frequent barriers to goals of care discussions. We conducted a pilot, single-center, three-phase pre-post implementation study using mixed methods to assess the impact. We included all of the intensivists except myself because I was biased in knowing what the primary outcome was and what we were looking for. So all other intensivists except myself were included in the study. We included patients who were 65 years and older that were capable to consent to research based on the clinical judgment by their intensivists. And the patients that were included had to, not the patients, but the clinicians had to have the intention to discuss goals of care with their patient so that the patient would be then approached to ask if they'd accept to participate in the study. We video and audio recorded all of the goals of care discussions during 6 months for the patients who accepted to participate, and evaluated the impact of our implementation with structured tools before and after the interventions. In addition, we also conducted a qualitative content analysis of the recordings to get a better sense of the impact of our intervention. So we used the option scale, the 12-item option scale, to measure the level of involvement of patients by their intensivists. And we used a subset of the accept quality indicators used to assess the quality of goals of care discussions. And 2 researchers trained in qualitative analysis performed the content analysis. So these are the 3 phases of our study. The first phase, we video and audio recorded dyads of patients and their attending intensivists discussing goals of care without the use of our decision aid. Then the second phase, we allowed clinicians to access the decision aid that we had created, but without any prior training. Between phase 2 and 3, we asked the 5 intensivists to complete the online training. And after the training, there was a debriefing session to make sure that there were not any outstanding questions from the participants, the intensivists. And in phase 3, we then video recorded and audio recorded another set of dyads of patients discussing with these intensivists who had received the training. The two reviewers actually revised and analyzed the video recording using the option 12 items and the selected accept quality indicators. The reviewers were trained on the use of the option scale that was adapted to the index problems, being CPR and mechanical ventilation, and the available options that were to so either attempt the interventions or not to attempt CPR or mechanical ventilation. And each item of the option scale was rated on a 0 to 4 scale, 0 being the behavior not observed and 4 the behavior being observed at an excellent level. And we had those all defined very clearly. This is the flow chart of our study. We assessed 359 patients for eligibility, and 313 were judged not eligible for many reasons. The main one were the fact that intensivists didn't intend to engage in a goals of care discussion, which surprised us to the extent of how many patients were not going to get a goals of care discussion. Many of the reasons for these were that these patients were being admitted by other specialists as the primary treating physician. For example, a surgeon who admitted a patient post lobectomy for lung cancer, for example, and the intensivist didn't feel comfortable in reviewing the goals of care that had been determined by the surgeon preoperatively. In the end, we had 46 eligible patients. 25 who were eligible were not recruited for different reasons. Some had declined to participate. 3 missed discussions, and 16 discussions that were planned but did not occur for a variety of reasons. The patient was discharged prior to having the discussion, or the physician or the unit was too busy, and 1 patient died. In the end, we had 21 participants in our study. These participants were mainly men, 71% were men. The mean age was 76. Almost all were French Canadian, 95%, and Christian, 95%. We had a relatively high rate of participants not having completed high school at 57%. 52% were married. Most of the patients admitted were admitted for medical reasons. 66% were medical patients and 33 were surgical. The median length of stay in the hospital was 16.8 days. The median length of stay in the ICU was 7.5 days. And for our intensivists, most were men, 80% were men. The mean age was, or median age was 37, and 7 years of median experience post-residency, and all had fellowship training in critical care. So this table shows the scoring for each of the 12 option items on the option scale. I won't go through all of them. I'll mainly attract your attention to the total scores that show that there wasn't really any difference between phase 1, phase 2, or phase 3. And another important point to understand is that between during phase 2 and during phase 3, none of the intensivists actually used the decision aid that we had asked them to use or had trained them to use in phase 3. In phase 2, they had no training, but none of the intensivists reached for the decision aid as a support during their goals of care discussions. So all of the intensivists completed the online training between phase 2 and phase 3, and all participated in the feedback session. As I previously pointed out, none of the intensivists used our decision aid. And finally, there was no difference either between the different phases when we looked at the accept quality indicators for high quality goals of care discussions. And this table is a summary of the grading using the accept criteria. And again, I won't go through all of them, but I'd like to point out the important points. Is for criteria 2, you can see here that none of our clinicians actually provided the patient and or their family with information about goals of care. This would have been our decision aid between phase 1, 2, and 3. Phase 1 is natural because they didn't have access to it at that phase. During the discussion, none of the intensivists actually pointed out their assessment of potential poor prognosis or indicated in some way that the patient might have a limited time to live. Another important point is that even though these first two criteria seem pretty weak, what is reassuring is that after the discussion, documentation of goals of care is present at a high compliance level throughout all phases. And another reassuring point is that after the discussion, the goals of care that are documented in the medical record are consistent with the patient's stated preferences that were documented during the video recordings. Some of the qualitative results that we have are interesting to point out as well. We noted many barriers to adequate discussions during the discussions. Many patients had hearing difficulties. There was potential for subclinical delirium versus confusion. We noted that a lot of the patients took a long time understanding what the discussion was about. In many discussions, the option of CPR and mechanical ventilation are discussed in detail, but not the option not to perform CPR and or mechanical ventilation. And the option of palliative care was never addressed in the 21 discussions as an alternative option to aggressive life-sustaining therapy. And this explains our low option scores, because both options, that of offering CPR and or mechanical ventilation, and the option of not performing CPR and mechanical ventilation and potentially palliative care, must have or had to be presented to get high option scores on that element of the option scale. And a very, I would say, representative verbatim or transcript of that illustrates this point is a physician stating that if your heart gives you any trouble, the only option we have is to give your heart some shocks and compressions to try to restart it. So this really illustrates our mindset as intensivists, that we're trained at resuscitating, we're trained at using these very aggressive life-sustaining therapies, but we forget to talk about often the less aggressive and more palliative care approach to these patients. Another interesting qualitative result is that the word death is often replaced by euphemisms that we had previously noted in our other study. Physicians will use the word to let you leave, as I previously pointed out, or close the books. These are translations of what was officially said in French, but it's really meant to illustrate what type of vocabulary we use as clinicians or intensivists. If ever God comes and gets me, I don't want you to give me any compressions or shocks and restart the machine. And this is actually a patient talking. So it's not only euphemisms used on the side of physicians, but also patients tend to use euphemisms to talk about death. And so this brings me to my final slides and a discussion about, so we found that the implementation of interventions to improve the quality of goals of care discussions between intensivists and patients is a difficult process, even at the level of a single ICU. The avoidance of talking directly about death and dying during discussions about goals of care was frequent among intensivists in our study. Many of the discussions showed communication barriers that limit the capacity for patients to engage in shared decision-making. However, in the end, the documented goals of care in the medical chart seem to be consistent with patients' expressed preferences during discussions, which is reassuring. The limitations of our study, one is that our decision aid was not used, and we hoped that it would be used so we could assess its impact, but since it wasn't used, we can't say that our decision aid had any influence. So we still need to explore the reasons for this. We have to think of potentially going back to the drawing board and simplifying our tool or reassessing why it wasn't used. One of the potential reasons is that our tool originally was developed with patients in the ICU, but who were younger, less ill, and capable of interacting with us to give us feedback. So potentially our tool still needs to be simplified and adapted to the context in which it will be used. Our discussions were observed in non-urgent contexts with capable patients, so our results potentially could inform discussions with family members, but the discussions that we often have as intensivists with family members to identify goals of care for their patients adds complexity to these decisions and would need a different study. Patient recruitment was harder than planned. As I said, goals of care are sometimes already discussed by admitting physicians, and some intensivists do not want to revisit these discussions with patients, making it sometimes difficult to study with intensivists. Also, the intensivists are very busy. They have lots of competing tasks, and so it's sometimes hard to engage in difficult goals of care discussions. The option scale is a tool to assess the quality of shared decision-making and was not designed to measure the richness of goals of care discussions. So it helped us determine if clinicians engaged in shared decision-making or not. We have overall low scores of our option scale, but it really doesn't assess the richness of what patients are saying, and it's one element of the evaluation. And the qualitative side of our evaluation was really very helpful in adding the richness to our results. So in conclusion, we note that there is still a need to improve clinicians' communication skills related to goals of care discussions. We think that there could be a potential for video recording to offer actually feedback. So to turn video recording into not only a capture of a tool to measure shared decision making, but it actually could be used as a tool to provide feedback to our clinicians and help them learn how to better integrate the different elements of shared decision making. An ideal decision support tool and decision aid still needs to be developed and needs to be adapted even more to the context of critically ill patients in the ICU, but also to the cultural context and literacy of these patients that potentially still needs to be improved. And finally, as we reflect on our results, we think that there are many other interventions that need to be explored to support high quality goals of care discussions, being pre-ICU interventions, having better involvement of primary care in the discussions and sharing of information, or preparing patients for this discussion before they get to the ICU. And I think also as intensivists, we probably have to improve our own ICU discharge process, where we would re-explore or restate the goals of care with patients. We also potentially need organizational policies to support system-wide high-quality goals of care discussions, and involve many other professionals in the goals of care discussions, being nursing, social workers, palliative care, geriatrics, and spiritual care. In our unit, as it is now, the nurses do support the discussion, but I think there's a higher role that they could play, and the involvement of a team approach to goals of care discussions would be very interesting to explore, and potentially would also help us potentially use our decision aid more appropriately, or improve its use. So that concludes the webinar. I'm very happy to take any questions, comments, and suggestions.
Great, thank you very much. That was a great presentation, and really highlighted the huge challenge that we face in a very complex environment of intensive care, and many players involved in the decision aids and just creating those support tools for the physicians and the patients. So We don't have too many questions, but we'll get us started here right now. It's interesting that you use videotaping of the patient-physician encounters. So what did this look like? Who was videotaping? What were some of those barriers, facilitators of that process?
Yeah, sure. So the question, I guess, is to give a better description of how we used video recording in our study.
Yes.
Yeah, so we once a clinician had identified a patient where a goals of care discussion was needed, the research team was alerted to this, and the research team, with the acknowledgement of the clinician team, met the patient and asked the patient if they accepted to participate in our study. That was presented as a study that was aiming at improving the way clinicians discussed and talked about goals of care with their patient. And the process of the study was explained, where that patients, if they accepted to participate, would be either video recorded or audio taped. And we did express a preference for the video recording. And out of all of the patients who participated, only one only accepted the audio recording and not the video recording. And so we were actually quite surprised at the high rate of acceptance of video recording. And initially there was definitely shyness on the part of clinicians when we presented the idea. Patients also expressed some resistance or shyness in potentially being videotaped. But in the end, clinicians and patients alike forgot that the video was there. It was a very small GoPro camera that was actually connected to a post in the room, or hooked up to the bed. And as the conversation between the intensivist and the patient started, rapidly the idea of having a video recording was forgotten. A member of the research team was present during the recording to make sure that the video wasn't having any problems, but even the presence of a research team member wasn't perceived by our patients, or from what we observed, as causing unease or discomfort on the side of patients, and neither on the side of the intensivists. So all in all, it was a very positive experience, and that's why we think that potentially using video recording as a educational tool for the intensivists who are actually leading these discussions might actually be something that could be very helpful as we move forward in teaching communication skills to clinicians.
Great. Yeah, that's a good point. I have a question coming in here. There are quite a few here now. So we'll start off with, do you think that the discharge planners could be trained to use the decision aid, and have you attempted this?
I definitely think that they could be trained at using our decision aid, and but we did not study this. And I think as we look at transitions in care, I think we should definitely focus on the discharge planning of patients from the ICU to the wards, whereas intensivists could actually sit down with the patients and review what has happened if ever the patient had undergone CPR or had been mechanically ventilated or had been dialyzed, for example, and review their experience and revisit the initial goals of care to see if patients still want those interventions in the future. And we haven't studied that discharge planning to see how often intensivists actually do revisit the goals of care upon discharge. And so I think it's a very interesting question to look at.
Okay, great. I have a question here from Dr. Greg Hirsch. He says, great presentation, a very important area of work. It seems to him that administratively, it would be reasonable to make it policy that decision aids are provided to patients over 65 with unanticipated admits to ICU. So for sure that discussion does not belong in the immediately post-op patient where ICU was anticipated. So in those cases where shared decision-making has to happen preoperatively. But for the 78-year-old with pneumonia, a decision aid optimally populated with individual risk should be provided and gone through by healthcare practitioners. What are your thoughts and barriers to that approach?
So the question did break up a bit, so I'm just going to restate what I understood from the question and make sure that I understood correctly. So
Sure.
The question is about the barriers to using the decision aid preoperatively, or is the question about the barriers to using the decision aid with a population who is admitted with pneumonia, for example?
Yeah, so that the older person, about 78 with pneumonia, that should have some sort of understanding of their individual risk. So what are your thoughts and barriers about, like, the barriers to that approach and approaching that kind of a patient?
Yeah, so that's what our tool was. The specific population that our tool had been developed for was that 80-year-old patient who was admitted with pneumonia and at risk of needing mechanical ventilation. So our tool specifically addressed that population and not the population that was being planned preoperatively for an admission post-op in the ICU. So that might be just a clarification, but the barriers for using our tool in the population that we meant it to be used with were the ones that I pointed out, being the potential confusion that patients have, I would say undiagnosed delirium, whereas sometimes you think the patient seems like they understand the questions that we're asking them, but when we start getting into very complex questions and complex decision making, this is where we noted many barriers in the engagement of patients in shared decision making, where they just wouldn't understand sometimes the description of the interventions that we're trying to describe, and they didn't understand the pros and cons. And so this probably is one of the reasons why clinicians in our discussions weren't offering many options. They were being quite directive in their discussions, and that's one of the realities and the difficulties that we had in this model of really trying to engage the patients in clarifying what their values and preferences were. It wasn't across the board. I mean, there was a subset of patients, or a large subset of patients, that did engage with us, but so I would say the barriers would be confusion, side effects from medication. So patients might not be in delirium, but might have side effects from narcotics being given for pain control. The patients are also short of breath, and engaging in these complex questions is difficult with those patients. And so as we move forward, this is where potentially we need to address the lack of pre-existing goals of care and having the discussion with the patients before they become critically ill. And the decision aid that we developed would not replace the need for that part of the process to be done.
Right. Great. Thank you. Here's another perspective I have, and this one is more of a legal perspective. So the comment is, your tool appears to help this deficit that with patients are really like not having these discussions with their physicians about their goals of care. And while your decision aid seeks to try to help that, this lawyer sees that physicians may not be aware of the degree of discussion that's a legal requirement failure, of which to do this may result in claims of negligence, and which also takes away from the patient's rights to give or refuse informed consent. So what she wants to know is whether or not you've done a legal review of your decision aid, or do you include any information about the legal requirements in the discussion to get informed consent, as the latter would complement your tool and perhaps bring more authority to it being used.
That's a great point. We did not get legal review or even ethics review on our tool. I think that's a great suggestion. One of the suggestions that enhancing its legal importance is an interesting point to explore. And I think if we were going to create a organizational policy for hospitals, the legal implications or the obligation to obtain informed consent would be important, I think, to highlight in that organizational policy. Now, this being said, there are situations, unfortunately, when we can't get patients' consent to proceed to these life-saving interventions, and when the patient hasn't previously expressed their goals of care, intensivists and emergency physicians have to proceed. And again, this decision aid and shared decision-making process won't necessarily help that clinical situation. But I do appreciate the suggestion to build this tool and support it with a legal opinion or a legal aspect to support its use. One fear I would have as a clinician is that making it more complicated than it is potentially going to reduce its use. So it would have to be more, I think, at a policy level than really specifically within the decision aid itself.
Great. So another sort of a different way of thinking about how we can enhance the use of the decision aid. We have a question about training of medical residents rotating through the ICU. So do the medical residents that rotate through, do they have an opportunity to learn skills and conversations about goals of care? So for instance, like perhaps this training that was provided to your the intensivists in your study specifically, maybe just was at the wrong timing, like they're already used to doing things in a certain way.
Mm-hmm. I think that's a great point. Yes, I agree that as we move forward, I think this training module definitely should be offered to all of the trainees going through our unit, but potentially within the other units in our university, or even shared across the country. I think, and there are probably many different training modules that exist in the different universities. I don't know to what point they were clinically or oriented towards shared decision-making per se, but as I pointed out, we did build our training module on 3 existing modules that touched on different elements of the communication skills that are needed to train future physicians in learning how to elicit goals of care and bring patients to make a decision about what they want. And so I would love for our training to be used more broadly, and one of the reasons for this study was to see if it was feasible to get the intensivists to do it and then explore the barriers and facilitators to the implementation. The training per se was not difficult to implement. As you see, the 5 clinicians did complete it. The satisfaction level was I would say, moderately high. We didn't present the results to that, but the comments and feedback were positive. So I think this kind of training should be made available more broadly, indeed. And it is available online, as I said in my presentation. So people can already use it.
Great, yeah. And so sometimes with intensivists, we have a comment here about, often the physicians feel like they know how to communicate with their patients and they don't need help. But so have you found or thought about any strategies to counter that sort of feedback from the intensivists?
Yes, you don't see my face because I am smiling, because that comment came back to us quite often during our study. And it's a comment that we often get from not only intensivists as well. I mean, many physicians claim to the fact that we do engage patients well and that we discuss this question well. But when we observe the patients and the clinicians in these goals of care discussions, there definitely are areas of improvement. So that's where I think having the video recording would actually be a great mirror for us as intensivists to show us our shortcomings and where we can improve in a very proactive and a very positive way. I think if we are open about the way we engage patients in their goals of care, and we make it as an objective for us to improve and to continuously improve, the video recording facility would definitely be helpful in providing feedback, and the clinicians would actually see where they can improve. So I totally agree with that comment as well.
Great. So we have so many questions here still, but we are at the 1 o'clock mark. So I'm going to have to close it down now. And I encourage everyone who has a question, a burning question for Dr. Archambault, to send him a message. His contact information is up on the screen. And so thank you once again for a great webinar and a great chat session here. The survey will be popping up on the screen after the webinar, so let us know what you think and how we can continue to improve. Thank you, everybody.
Thank you very much.